Hello and welcome. You're watching Global Insight with me, Woo-Young. From Arirang News Centre in Seoul, we speak with experts from around the world to hear their views on issues making headlines. Even as COVID-19 vaccinations begin across major countries, we're not out of the woods just yet. Until most of the populations across all societies are protected against the coronavirus, it's clear life won't start going back to normal and transmissions may well just continue. As we prepare to live another year with COVID-19 among us, we try to picture what this will look like. And for this, we welcome back well-renowned immunologist Peter C. Doherty, who was awarded the Nobel Prize for Physiology or Medicine in 1996. An Australian immunologist and professor at the University of Melbourne, Peter C. Doherty's Nobel Prize-winning research revealed how our immune system how they recognize or may not be able to recognize virally infected cells. Today, his institute, the Peter Doherty Institute for Infection and Immunity, was the first in the world outside China to sequence the COVID-19 genome, grow the virus, and share the results internationally. Dr. Doherty, thank you so much for coming back to our show on Global Insight. It's lovely to see you. How are you?
I'm very well, and I hope you are well in Korea, because we're hearing you've had a flare-up of the COVID.
We certainly have. And well, Australia, though, are handling it very well. And well, actually, both our countries like South Korea and Australia, we're not really in a rush to roll out wide-scale vaccinations like they are in Europe and Northern America. So some people are getting worried. I mean, is that okay that we're not going straight into the wide-scale vaccinations?
Well, certainly that's true in Australia, because at the moment we have very, very little disease. We have currently an outbreak in Sydney where the virus got out of one of the quarantine hotels, where we're putting returning Australians and anyone travelling into the country. And there's been an escape there, so there are some community cases. But our contact tracing and testing is very comprehensive, and I expect it will be stamped out very quickly. So we don't actually need a vaccine in the sense that the northern countries need vaccine when they're facing really severe situations in many European countries and North America and so forth. So vaccine is in limited supply. And so obviously the first rollouts will be in those situations. We will need vaccine when we decide that we're going to open up the country to international travel. And in fact, we'll probably start to roll it out in about April next year, I think.
Right, and is it okay for members of the public, though? Is it maybe in countries like South Korea where we're seeing numbers go up a little bit? Is it okay right now as to just wait and see how the vaccinations are going before deciding to just deploy them at a massive scale?
Vaccination, like any medical procedure, is also always a risk-benefit equation. And if you're in a high-risk group with COVID, the elderly, frontline medical personnel and so forth, that risk-benefit equation is obviously very tilted in favour of the vaccine, because the vaccine has been tested for safety and efficacy. It's been a rapid process compared with earlier vaccines, but I don't see any real evidence that it's been compromised in any way, and that it is being rolled out as an experimental vaccine. My son, who's a neurologist in Seattle, for instance, has just had the Pfizer vaccine, one of the mRNA vaccines, totally new technology, but it looks really good. And so I'm not personally concerned. I would take any of the vaccines tomorrow quite happily, because I'm in a very high risk. I'm 80 years old.
Actually, while these vaccinations are rolling out, we're hearing about a new strain of COVID-19 circulating in the UK. Should we be a bit worried that the mutation of the virus is going to maybe outpace the effectiveness or the pace of vaccinations?
The strain of virus is circulating in the UK. I don't think it's that totally new. It's been around a little while, but it does seem to be more infectious and spreading more quickly. It's not causing more severe disease as far as we can see, But it does mean that there's a bit of a gap. If you get these new mRNA vaccines, I think you don't get much immunity for about 10 days or so. But even a single shot, they're double shot vaccines, is giving protection. So it maybe increases the risk after vaccination, but it does increase the risk that people will catch it, not that they will get a more severe disease.
Well, right now, the Moderna and the Pfizer vaccines, of course, are being deployed at a wide scale. But two vaccine candidates are being developed by a team of researchers from the Peter Doherty Institute for Infection and Immunity, along with the Monash Institute of Pharmaceutical Sciences. And they are protein and mRNA vaccines. So how are they coming along, the development of vaccines at your institute? And where do you plan to distribute them?
These vaccines are kind of late on the scene, but we've got to vaccinate an enormous number of people across the planet, and we don't really know how well any of the vaccines are going to work in the long term. We've got short-term results because we've just encountered this virus, and we know that these things are working in a relatively short term. But there are a lot of uncertainties about vaccination. So various countries, including, I heard about one that's being developed through a connection with South Korea, for instance, that are pushing ahead, though they're not nearly as advanced as the current candidates that are out there. I mean, the cost of their development is relatively slight with the cost of the disease itself, the enormous economic cost. So, and how far they'll go, we're not sure. But so far, the vaccines that are being made here look fine, and they're going into various early stage tests, but they haven't gone into humans yet. And so we'll persist with it because it's really not that expensive, and it may be a backup fail-safe if things don't go as well as we hope with other vaccines. And there may be a market for them anyway because of such enormous requirement for vaccine.
Well, the steady progress is really very encouraging, very reassuring to hear, because these days we hear so much about some countries that don't have access to the Moderna and Pfizer vaccines, so we'll need as many as we can get. And well, now, Dr. Doherty, your revolutionary findings about the T cells and how their ability to recognize foreign agents like viruses in the body can be affected by a cluster of genes called major histocompatibility complex it's really offered innumerable insights into autoimmune diseases, graft rejection, organ transplantation, and of course, vaccine design. And these days we have researchers and IT businesses building upon the knowledge that you brought to the world to really optimize predictive medicine and genotyping based on things like artificial intelligence, which is really helping save lives with a lot of applications, including in organ donations. I mean, what do you make of all these developments that have emanated from your crucial findings? And also, what applications or technologies do you hope to see more of?
Well, the discovery you talk about was made with a Swiss colleague, Rolf Zinkernagel, who's a bit younger than I am, and we shared the Nobel Prize. But it was made in 1973, 74. So it's a very long time ago. It was a major discovery. It told us a lot about how one half of the immune system, the cellular immune system, works. And over the decades, that's been applied in all sorts of situations. And of course, it's been central to understanding how those responses work. And these are the types of responses that are being manipulated for cancer immunotherapy. We are interested in them in vaccines, though most vaccines don't generate much in the way of that type of response. The mRNA vaccines should, but the vaccines that we're making now against COVID are not heavily biased in that direction. You'll realize that COVID is a complex RNA virus. It's a very big one. And we've never made vaccines for humans before against these things. And so, and we're only making the vaccines against one small part of the virus. It's the spike protein, and the receptor binding domain of the spike protein. So it will stimulate some of those types of responses, but the main focus is to make antibodies against that receptor binding domain of the spike protein. That's what we're really targeting. The cellular immune response, we would probably need to put more viral genes into our vaccine if that's what we're after. But that's not normally what we're after with vaccines. We're interested in them and how we recover from infection. We're interested in them in uses for therapy. But for vaccines, they could be very important because we don't totally understand the immune response to COVID. We've only had relatively short time to study it. And we could need to think much more about stimulating those responses, but they haven't been the primary target. And the vaccines that are being rolled out now are the vaccines that were developed to be made in very, very large quantities very quickly, the RNA vaccines particularly. So they're particularly appropriate for what we're facing at the moment.
Well, recent research has shown that people with certain HLAs, that they're more susceptible to getting COVID-19 and are a bit weaker when it comes to recovery. Does this mean that our genetics could largely affect our response to the virus?
Our genetics affect our responses to pathogens in ways that we're just really beginning to understand. And we're really beginning to understand that through the application of genomics. And so what will be particularly important in understanding the genetic susceptibility profiles of humans to these viruses will be to look at this massive genomic analysis, the new technologies that have come along in the last 10 to 15 years in the context of how well people did when they were infected, and that will have to be related to age and other susceptibility factors. And so that genomic profiling will be worked out in the longer term, but it's not been an acute thing because we're just trying to deal with a pandemic. Where genomics has been very useful is in sequencing the virus and using that to trace the origin of particular virus outbreaks or events. So genomic epidemiology has come out of this. With respect specifically to the HLA, yes, there are probably signals there that relate to whether or not some people make a better T cell response than others. The role of the T cells is in an infection like this, or the killer T cells, the ones that we studied, is not so much protection, though they can have a protective effect. Their primary role is to bump off the virus-infected cells, the factories that are making viruses within us. They're the assassins, the hitmen of the immune system. Now, when they're primed up, we do get immunological memory, as we get for the antibody-forming cells, and generating a more rapid response in a secondary infection or after vaccination, if we were targeting that, can be helpful. We know that can be helpful with flu, but they haven't been the primary vaccine target.
Well, for now, the world keeps seeing COVID case numbers just grow by the day, hitting new records, especially in the United States, Europe, and here in South Korea as well. We're seeing the numbers grow day by day. And well, vaccination, of course, it's not going to put an immediate stop to the virus. And throughout next year, how do you see the virus sort of playing out next year? Do you think we're going to have even third, fourth, or even fifth waves of the virus?
Yes, it's a continuing process in the United States and Europe, with it ramping up in winter, of course. When people are more indoors, it's more dangerous. And basically, that's part of what's happening at the moment. We're hoping that as we see vaccines roll out, case numbers will drop dramatically in those vaccinated populations, and that we will see getting to a level of where we've got herd immunity, both as a consequence of people being infected and becoming immune, and by being vaccinated. Now, we're not sure yet. We know that these vaccines have been tested to stop the development of severe disease, and the Moderna vaccine and the Pfizer vaccine both come in at about 90% in stopping the development of severe disease. We're not quite sure how much they'll drop transmission, but I think they will drop it dramatically, quite frankly. You know, transmission in COVID, we think it's only about 20% of people who are important in transmission. We call them super spreaders. And if we can knock those numbers down, we think we'll knock this the incidence of this infection down very dramatically. But that will be in the countries that are wealthy enough or privileged enough to be able to roll out those vaccines on a very large scale.
Exactly. The Pfizer and Moderna vaccines they're incredibly expensive. They're much more than the minimum wage in most countries. And, well, do you think there are soon going to be other vaccines on the scene that more countries will have access to? And how long do you think it will take for, well, most of the world to have that herd immunity against the virus?
I think we're talking about vaccination strategies that stretch through 2021, 2022, and even into 2023. Now, there is a lot of commitment on the basis of World Health Organization, Gavi, the Global Vaccine Initiative, and on CEPI, the Center for Epidemic Preparedness Initiative, which funded the development of some of these vaccines, to get these vaccines out across the planet. And the rich countries will help with that. And really, it's important for everyone, because the world's not going to return to normal economic activity until this virus is really stamped down. And it's costing us trillions of dollars, as we understand. So there will be an incentive there to get these out. And I think some of the companies have committed to, as far as the poorer countries are concerned, ensuring they can be distributed at cost. India has a very strong profile in manufacturing drugs and vaccines for developing countries and so forth. So I think we're going to see a lot more initiative in that direction. There's a great desire to do that, but I think it's highly likely that we'll see scarce vaccine rolled out in the wealthier countries first. But though a Chinese vaccine is being used in Indonesia, and I think the sooner we get these across into the poorer countries as well as the rich ones, the better for all of us.
Well, hopefully we'll see some encouraging developments from your institute as well. No pressure, but getting the distribution there out to the world. And well, for now, it looks like we're going to have to live with the virus in 2021 for most societies, even the ones that are administering vaccines. How will we have to live with it in 2021, Dr. Doherty? And just looking at this pandemic as a whole, what do you think this really taught us about how we should prepare for another global pandemic?
Well, I think we need, as far as preparing for another global pandemic, we need to look forensically at every aspect of this. The sociology of it, the science of it, the epidemiology of it, the economics of it. And we've got plenty of different experiments across the planet with countries handling it well or badly, and we should compare them and take home the lessons of how to deal with this. We know that we've had 5 of these viruses, 5 of these coronaviruses, jump across from bats into us over the last 20 years. Now, prior to that, there were only 2 of those viruses circulating in the human population, 2 common cold viruses, which we'd known about since the 1960s. Now we've got 5 new ones. 4 of them are still circulating. The original SARS burnt out. The Middle Eastern respiratory one, which is very bad, it kills about 30% of people, is still circulating, but at a very low level. And we've got 2 new common cold ones, which have gone globally, and we've got COVID-19, SARS-CoV-2. So it's very obvious that something serious has changed in the matter of getting viruses around the planet. And the obvious thing that has changed, the most obvious thing, is mass international air travel and mass tourism, including from countries that maintain live animal and live bird markets, which are part of their culture, and that's for national governments to address. But they're undoubtedly a danger when it comes to viruses jumping from wild animals into us. And so we're going to think a lot about it. We should analyze it very forensically. And I think personally we should change a number of the ways we do things. We've realized in Australia that casualised workforces with people working multiple jobs are extremely dangerous when it comes to epidemics. We've seen a lot of public health services around the world run down as the economic rationalists and libertarians have taken government control, and we've transferred more and more money to rich people and less to public good or to poor people. There are a lot of things we need to do, but it's undoubtedly the case we'll see more of these, and it won't be 100 years, it'll be 10 years or less. And so we need to be much better prepared. We've learned a lot about vaccines and how to get them out fast. The other thing we could have done, and we didn't do, is we could have prepared class-specific antiviral drugs which would have worked against all the coronaviruses. We have them for influenza. We have them for HIV/AIDS. For flu, you've got to roll them out very quick. But in a pandemic, that's not such a problem. So there's a lot we can do and a lot we need to prepare to get ready for it. Coming out of the pandemic is going to be difficult, especially for countries like Australia, because we've dealt so well with it that we have a totally susceptible population. We're going to have to require that people flying to this country have vaccine certificates. We're going to have to require perhaps that they still be tested as they come in. I don't know. There are a lot of rapid tests being deployed, not quite as accurate as the gold standard PCRs, but can be used to screen people like airline passengers. That has to be worked out. A lot of people are talking about this, how to do it, how to move to the next step. It has to be based in science, and it will be done well in countries that have had good political leadership, and it will be done badly in countries that have had bad political leadership. South Korea we regard as one of the good ones, but you don't find it very hard to identify those countries that have had terrible political leaders.
Exactly, and then going forward, hopefully, well, world leaders will listen to you, sir, and public health officials as well. And just until now, it's seemed like a choice between science and the economy, but in all of this, in all of our responses, we have to remember that at the end of the day, the bottom line is it is about people's livelihoods. So as you mentioned, we really need to focus on all aspects, the social aspect, economic aspect, and of course the health aspect as well. Well, we've taken up quite a lot of your time, so we'll let you go now, sir, but thank you so much for your insights and for taking the time to share these really crucial facts with us and our viewers around the world. That was Peter C. Doherty, immunologist and professor at the University of Melbourne and Nobel Laureate of Physiology and Medicine in 1996. Again, thank you for joining our programme and a very Merry Christmas to you, sir, and have a very Happy New Year.
And the same to everyone in South Korea. It's always a pleasure to talk to our friends in South Korea who are so effective in everything they do. An admirable country and good friends.
Thank you so much, sir. And to our viewers, thank you as always for watching.